Hey everyone, welcome back to The Explainer. If you're prepping for your medical board exams right now and you need to completely crush the infectious disease section, well, you are in the exact right place. Today, we're taking some pretty complex clinical protocols and turning them into a high-yield, rapid-fire review.
All right, let's just jump right in. Look, malaria isn't just about memorizing that you get it from a mosquito bite. Board examiners really want to know if you can differentiate the species, manage a crashing patient, and actually dodge their brilliantly crafted diagnostic traps. So we're going to strip away all the fluff today and focus purely on the high-yield facts that will literally get you points on exam day.
Here's our game plan for today's boot camp. First, species and distributions. Then, severe falciparum pathogenesis, followed by high-yield diagnostics, clinical treatment protocols, and finally, we'll wrap up with the ultimate exam traps.
All right, part 1, species and distributions. Take a look at how distinctly these species behave. P. falciparum, over on the left, that's your deadliest one. Why? Because it invades red blood cells of literally all ages, which leads to massive parasitemia. Now, on the other hand, P. vivax is kind of picky. It only wants young reticulocytes, and it absolutely requires the Duffy antigen to even enter the cell. And don't miss those blood smear features. Vivax gives you those enlarged red blood cells with Schiffner Stotts, while P. malaria prefers the older red blood cells and presents with that really unique 72-hour Quartan fever, band trophozoites, and Rosette-Shazan.
But wait, there's an emerging zoonotic threat you really need to know about. P. knowlesi. This is a massive exam target right now. It's found in Southeast Asia, and it uses macaque monkeys as a reservoir. But what you absolutely have to remember is its vicious 24-hour quotidian fever cycle. Because it replicates every 24 hours, it causes rapid, severe parasitemia, just like falciparum. But, and this is a huge but, it causes no cerebral malaria. It's also dangerously easy to misidentify as P. malariae under the microscope.
Real quick, before we leave this species, we got to talk about the liver. P. vivax and P. ovale have this secret weapon, hypnozoites. These are dormant liver-stage parasites that can cause clinical relapses months or even years after the initial infection. So the crucial takeaway here is that just clearing the blood, that's not enough. You have to achieve a radical cure using primaquine to totally eradicate those hypnozoites.
Moving right along to part 2, severe falciparum pathogenesis.
So, let's look at the true danger of falciparum, which is cytoadherence. After invading a red blood cell, the parasite creates these little knobs on the cell's surface. These knobs extrude an antigen called PFMP1, and you can think of it like biological superglue. It binds to ICAM1 in the brain, CD36 in most of your organs, and VAR2CSA in the placenta. This makes the infected cell stick directly to the blood vessel walls, a process called sequestration. And because these mature forms are basically glued deep inside your organs, causing microvascular obstruction and lactic acidosis, when you actually draw peripheral blood, you're only going to see the early ring forms.
So, what's the line between standard malaria and a crashing patient? Well, uncomplicated malaria gives you your classic fever, rigors, and thrombocytopenia. But severe falciparum? That crosses a hard line. Look at the criteria here. Coma, ARDS, hemoglobin dropping below 5, blood glucose crashing below 2.2 millimoles per liter, and hyperparasitemia over 5%. And here's a classic board pearl for you. In cerebral malaria, you'll see diffuse encephalopathy and maybe some retinal hemorrhages, but you typically will not see focal neurological signs or meningismus.
You've also got to watch out for this terrifying complication called black water fever. This is massive intravascular hemolysis that results in extremely dark red or brown urine. Keep in mind, this is hemoglobinuria, okay, not your standard hematuria. It can happen spontaneously, often tied to a G6PD deficiency, or sometimes it shows up as delayed hemolysis after artesunate treatment.
Okay, section 3, high-yield diagnostics.
The thick versus thin smear. They love testing this, and it's so easy to confuse. The thick smear is all about volume. It's literally 40 to 100 times more sensitive. You use the thick smear to detect if the parasite is actually there and to quantify the parasitemia. The thin smear, on the other hand, is basically your magnifying glass. You use it to look at the specific morphology so you can achieve exact speciation. And for both of these, the preferred Romanowski stain is Giemsa at a very specific pH of 7.2.
Okay, I want you to picture this clinical vignette carefully. You're reading a question stem. The patient comes in with a fever after traveling, but you notice they have a completely normal platelet count. What does that actually mean? I will say this loud and clear. If you see a normal platelet count, question the diagnosis of malaria.
Thrombocytopenia is incredibly typical in acute malaria. Normal platelets are just a massive red flag in board exam question stems. They're meant to steer you toward a completely different diagnosis.
All right, on to Section 4, Clinical Treatment Protocols.
When dealing with severe malaria, IV or IM artesunate is the absolute undisputed king. It significantly reduces mortality compared to those older quinine protocols, and importantly, it's safe in pregnancy. But, just as important as knowing what to give is knowing what not to give. Examiners absolutely love offering you harmful adjuncts as trap answers. Do not give glucocorticoids. Do not give mannitol. And absolutely, under no circumstances, give large fluid boluses. Unlike standard sepsis management, flooding a severe malaria patient with fluids is incredibly dangerous and can trigger deadly pulmonary edema.
Now let's look at the workflow for PVVAX and OVALI. This is a mandatory 3-step process. Step 1, you clear the blood stage with chloroquine or an artemisinin-based combination therapy. Step 2, you must check the patient's G6PD status. Why? Well, because of Step 3, administering primaquine or tafenoquine for that radical cure of the liver hypnozoites we talked about. If you skip Step 2 and give primaquine to a G6PD deficient patient, you are going to cause massive, life-threatening hemolysis.
Now, what about prophylaxis? Notice the stark contrast in these timelines. If you prescribe adafocone proguanil, the patient only needs to take it for 1 week after leaving the endemic area. But if you use doxycycline or mefloquine, they've got to continue it for 4 full weeks. And remember, mefloquine is completely contraindicated in patients with psychiatric disorders, seizures, or cardiac conduction abnormalities. Finally, Section 5, Ultimate Exam Traps. Listen, if you ever see the phrase banana-shaped or crescent-shaped gametocytes on a blood smear description, just stop reading right there. It is pathognomonic for P. falciparum. It instantly gives away the diagnosis. Notably, these mature gametocytes aren't killed by most antimalarials, so seeing them a bit later doesn't necessarily mean your treatment is failing.
Next up is the P. malariae trap. Do not miss this specific triad. If you have a patient presenting with a fever exactly every 72 hours, the Quartan fever, coupled with banned trophozoites on the smear, that should immediately make you look out for Quartan malarial nephropathy. This is an immune complex injury to the glomeruli that leads to nephrotic syndrome. It's uniquely tied to P. malariae, and unfortunately, it responds pretty poorly to antimalarials.
Let's rapid fire through a few more of these. First, quinine toxicity. Quinine actually stimulates the pancreatic beta cells to secrete insulin, which causes severe hypoglycemia that can mimic a cerebral malaria coma. Second, rapid diagnostic tests that use PH-RP2. Those can remain positive for weeks after successful treatment, so don't misinterpret that as a persistent infection. Third, a genetics trap. West African populations who lack the Duffy blood group antigen are naturally protected against PVVAX because the parasite literally cannot enter their red blood cells.
And here is a hard and fast rule you simply cannot violate on test day. Serology has no role in the acute clinical diagnosis of malaria. None. Serology is only useful for retrospective epidemiological research or maybe screening blood donors. If you have an acutely sick patient sitting in front of you, you need blood smears or rapid diagnostic tests. Never serology. Let's wrap up with one final thought. Imagine you're analyzing a thick smear, and you notice that more than 5% of the patient's neutrophils contain phagocytosed malarial pigment. Well, it means a recent, massive schizogony just occurred. But ask yourself, if you see this major indicator of a poor prognosis, how does it immediately alter your next step in management to prevent sudden systemic collapse? Keep your eyes peeled for those microscopic details, trust your clinical protocols, and you are going to absolutely crush your boards. Thanks for joining us, and we'll see you in the next explainer.